Good afternoon, everybody. This session, I'm really just introducing a very special guest speaker, Dr. Andrew Hill, CCIO, St. Helens and Knowsley, who's got a very interesting story around positive change in the pandemic at St. Helens and how the deployment of EPMA or ePrescribing has had major benefits to them in their organization. But first, I'm just going to give you a little bit of background on some other work that WellSky and our customers have been doing in terms of the pandemic. And if I could go to the next slide, please. So very quickly, by way of introduction, WellSky, some of you may be familiar with the name JAC, been around for over 40 years in partnership with the NHS, rebranded to WellSky a few years ago. We have a medicines management platform that's widely used across the NHS, as well as other parts of Europe and South Africa, and covers the principal areas around pharmacy, e-prescribing, chemotherapy, as well as more recently, mobile-enabled solutions for closed loop, not just for medicines, but supply, blood tracking, and a host of other applications as well. Recently now, solutions are very much available in the cloud as part of cloud-first strategies across the NHS. So if we could go to the next slide, please. So at the start of the pandemic, when it hit the UK, as you all know, there was a rush to get many of the Nightingale hospitals up and running. And we were involved with the Barts Hospital in setting up pharmacy at the exhibition stadium at the very beginning. Fortunately, they didn't need all 4,000 beds, but we did have to move swiftly, and we were able to implement within a week a pharmacy system and a pharmacy on site. And Nahid, the deputy chief pharmacist here, sort of quoted how this was all done within a week, a process that may often take many months. And it really demonstrated how collaboratively we were able to move at breakneck speed to ensure that we were ready for whatever hit us. In addition to that, we worked extensively with many other customers throughout the UK in terms of consultancy and licenses and support at that very early critical stage. Next slide, please. Some examples really ahead of Andrew's particular detailed example at St. Helens. We have seen some positive change early on in the process, in the outbreak. A lot of projects were stalled. And then there was a sudden realization of the benefits that digital solutions such as EPMA can bring in supporting frontline clinicians and helping patients in what was a very difficult new environment for them. And this then resulted in acceleration of many projects. And these are just a few examples. Up in Scotland, Greater Glasgow, they're currently halfway through a project which was started just around the beginning of the pandemic, a project that was supposed to roll out EPMA across the whole 8,000 bed organization, 2 to 3 years. But they soon realized that they wanted to move faster than that. And actually, with our support, they were able to build and configure the system in less than 2 months and a rollout plan over 5 months. And part of this was fear and readiness for the second wave, which sadly we seem to be about to hit or in the middle of. Other areas around outpatients was a notable area, which traditionally was left sort of at the end of a project to roll out e-prescribing. But the value of bringing that forward was certainly seen. And Brighton and Sussex University Hospitals had a plan to just start with inpatients in March, but accelerated outpatients first and went live in record time and was able to still keep their inpatients on track. Out in Jersey, a 2-ward pilot was also halted during COVID, but then they saw the need for remote COVID work, and they went live with a big bang approach on 9 wards within 2 weeks. And a couple of our more established customers at Norfolk and Norwich and Southampton also previously adopted a slower approach to outpatients, but during COVID identified the clinical benefits of this, which Andrew, I'm sure, will outline in a little bit more detail in his presentation. And they rolled out outpatients in 2 to 3 days, again, a process taking many months traditionally. Next slide, please. Really, to summarize my introduction, what has happened in terms of positive effects on the pandemic and with EPMA is the attitude of customers and also of companies like WellSky to work in partnership to enable things at a faster pace, and recognizing that need for change during a crisis certainly accelerated thinking and then actually roll out. So projects then moved at pace, whilst also having to adopt a fairly pragmatic and dynamic approach to risk management during those projects to ensure that patient safety was maintained. So these were just a few examples, and it's my pleasure to introduce Dr. Andrew Hill. And if we could go to the next slide, thank you. The CCIO at St Helens and Knowsley. And I hope you're there, Andrew, and I'd like to hand it over for you to your experience.
That's lovely, thank you very much. Just checking, can you hear me all right?
Can hear you loud and clear.
Lovely, right, okay, fantastic. So my name is Andrew Hill. I've been Chief Clinical Informatics Officer at St Helens and Knowsley since January. Prior to that, I was the clinical lead for our EPMA rollout before that. So fortunately, EPMA was one of the areas that we'd been quite strong in prior to COVID. If I move on to the next slide, if that's all right. Lovely. So just to give you a little bit of background about who we are. So St Helens and Knowsley Teaching Hospitals is a fairly large teaching hospital. It serves a population of 250,000 people across mid-Mersey. You may gather that Knowsley is really the place to be for COVID at the moment. I think we're currently second highest rates in the UK and climbing quite fast. So it's certainly been interesting times in wave 2 at the moment. We've got a total of 3 main sites. We have an acute site, which is Wiston Hospital, which has one of the largest emergency departments in the northwest and quite a big medical take. We've got our elective outpatient site, which we're increasingly using for cold site work, based at St Helens Hospital, which is in the photo. We've also got an intermediate care facility based at Newton Hospital. And on top of that, we offer a number of community and primary care services in addition. Knowsley, I think it's fair to understand we've got very high levels of social deprivation in the area. I think we often point this out, and and obviously there are many organisations carry some areas of social deprivation. Knowsley, until recently, and I think it might even still be the case, wasn't able to offer A-levels at secondary school. So as a measure of social deprivation, that's quite a significant marker. So I became Chief Clinical Informatics Officer in the January. In the February, we were picked to be one of the new digital aspirant sites. And so our first 4 weeks were filled with hope and aspiration as we planned a very extensive electronic record program to bring us more up to date with some of the other areas of our IT infrastructure. And then obviously very, very quickly, everything had to get rearranged in terms of what we were doing and prioritization. So we were delivering all of the things we were before and a load of new things as well, and in a different order from the things that we were doing originally. If I can just move on to the next slide. Lovely, thank you. So this has been a real challenge for us, and I think, as Rob touched on there, it's also about how EPMA is part of that system and how you move all of the systems on together. Prior to COVID, so as I said, I was the clinical lead for the EPMA project before I took on the CCIO work. And so back in November of 2018, we started off with a prolonged pilot phase on 2 of our acute wards. That gave us time to adjust our drug dictionary and our processes in pharmacy and tidy those sorts of things up. And then we did a large-scale deployment of about 2 to 3 wards a week over a 5-6 week time frame. across both our medical wards and our emergency department. Then in February 2019, we did a 3-week surgical ward deployment, and then we deployed on to St Helens. So we already had now a fairly established inpatient EPMA service at the time that that COVID hit. If I go next slide. The way we did our COVID deployment at that time was very, quite rapid, and we designed it to give a lot of hands-on support to enable us to deploy things really quickly. We did a very hands-on deployment, so we ensured that there was lots of training done prior to deployment. We did a full deployment survey, making sure equipment was up to date and working, that the Wi-Fi coverage was good. We offered a mix of training measures, so we offered face-to-face sessions, e-learning, super user support, so lots of close-on support. And then we provided an IT training team for about 2 weeks prior and around that deployment. And all of this was done with a very control room-based oversight on-site to deploy it. If we can move on. So that was how you could deploy these sorts of technologies prior to COVID. Obviously, things have now changed. So as soon as COVID phase 1 hit, we really noticed a significant need to reduce the physical contacts in and around the ward. So where we had ward pharmacists and junior doctors attending particularly cohort COVID areas, we really wanted to minimise the need to don and doff their PPE. We wanted to make sure that people weren't having to go into areas unless they absolutely needed to. So things that could be done remotely were very beneficial. We had shielding patients, so we had to think, how will we now manage a much more varied clinic infrastructure where we've got some essential things going on face-to-face, but as many things that can be done remotely as possible. We also had shielding doctors, which are or shielding clinicians. So we had a group of people in some key specialties that were unable to provide face-to-face clinical care, and we had to work our way around that as well. And then we come to Newton Hospital. So Newton was our intermediate care facility, and that was a group that we had already discussed and said at some point it would be a good idea to roll out in Newton. And then all of a sudden that became a must-do because we had an extremely vulnerable patient group. Intermediate care have similar risks to care homes. You've got very dependent patients in there. They've got long lengths of stay. We had a process of paper cardexes that remained in place at Newton, and our cover was provided by 2 GPs who themselves were high risk and potentially in contact with lots of patients. Additionally, our pharmacy cover was supplied between Newton and Wiston as our acute site. So those were really areas where we realised we were introducing a risk. If we go next slide. So the key risks really were that our GP cover was extremely vulnerable. We had no backup plan really in terms of our GPs. So we had to make sure that we looked after them as best we could. We had to try and get rid of Cardex rewrites in particular. Again, this was something that we appreciated was a good clinical safety thing to do on our acute site. But then with Newton, not only was it a good clinical safety thing to do, but actually the introduction of someone to come on the ward specifically to rewrite a Cardex now becomes a risk to the individual doing the rewrite as well as to the patient, as well as the transcription error risk as well. And the introduction of things like remote prescribing and checking then become a necessity rather than one of those nice to have benefits that we saw with our earlier rollout. So the idea that if we got stuck, someone could prescribe a medication from either of the other 2 sites or from the GP practice suddenly became a very key consideration. We also needed to think how we could utilise our specialists who were able and very willing to work, but unable to actually see patients face to face, and how do we get the most out of those? So what do we do with those key specialists who have and are still shielding? Next slide. So we've described a little bit about how we did the deployment pre-COVID. The post-COVID deployment was unfortunately obviously a very difficult and different scenario. We couldn't really deploy. At the time we then started to do the deployment, we had cases of COVID within Newton as well. So we were now in a position that we had a risk to people going on site. We had a risk of people on site bringing COVID onto the ward as well. So we really had to minimise our contacts between in and out of the ward. Fortunately, because we had considered some of the work beforehand, we had already surveyed the Wi-Fi, so we knew that our remote network access was okay. We had got equipment that was prepared and then delivered, so we could actually deploy equipment more or less, and more or less understood what our equipment needs were. So we had a few things that were going in our favour, and we'd also been there, done it, and got the T-shirt as well, which I think is a really helpful thing in this scenario. One of the major training changes is our training had to be e-learning and had to be remotely provided. So we could either provide remote, via Skype, via Teams type training, or we could do through the e-learning Moodle type packages. And so all of the training was provided electronically. We brought the cardexes out of the main ward area, transcribed them with one of our pharmacists, got them all checked and verified, and we went live really over the case of a couple of hours. And then a couple of our digital nurses and a couple of super users from the ward, from the other sites, agreed that they would just go on site and provide clinical support and also EPMA support for a couple of days afterwards. And then our IT team remoted in, which again is something that we really wouldn't have considered doing on the pre-deployment. I think one of the most impressive things about that was that we went from a decision to do it to an actual full deployment in 4 days, which I think, we thought we were being quite ambitious when we did a hospital rollout in 5 weeks, but going from this is something we should theoretically do some point to actually doing it in 4 days was pretty spectacular. And I suppose, unlike the pre-COVID, the benefits realizations are much more obvious immediately. So, our GPs, for example, sometimes had to provide some subcutaneous fluids or had to do smaller bits of prescribing, and we're doing it remotely immediately. So we'd managed to reduce the amount of contact that they had to have in that scenario. We also then started to introduce remote consultation for them as well, so they were able to Skype into the wards and things. So we really then started to be able to provide that package as well. Next slide, please. So this is really where EPMA then fits in with the rest of the work that has to be done around the hospital. So we did an event with Royal Lily towards the end of what feels like an age ago, but it was actually less than a year ago, where we were exploring video consultation as a thing. And at the time, it was this lovely idea that maybe some patients didn't need to come to hospital, and we were testing it on a clinic-by-clinic basis and gently introducing our patients and our clinical teams to this concept. So overnight, what was a theoretical model that we used with probably a couple of % of our total population, we were suddenly having to do at 20-30% rates. And so alongside our EPMA was a massive video consultation and telephone consultation outpatient service deployment. And with that, all the prescribing that actually comes from those clinics. Again, when we originally considered our telephone and our video clinics, we were mainly thinking we'll try and avoid those areas where we're trying to do lots of prescribing. Most of the consultations that we would be considering suitable for telemedicine are the sort where we can update a routine prescription from the GP, and at their next prescription they can update it, so changes to antihypertensives, for example. But now we're treating patients that really are much sicker via video conferencing than we would have considered possible back in December. And some of those patients, if you see them, you're seeing them in order to avoid hospital admission or to make urgent intervention. And so you actually need to prescribe immediately. Additionally, we didn't really want to send those requests off to the GP because that would just, their services are also disrupted and struggling. So we need to make sure they've got access to prescriptions now. If I can go next slide. So that then brought us to the idea of doing remote prescribing both for inpatients and outpatients. We'd already done some work on remote prescribing, as it says remote inpatient prescribing, but actually, it's remote prescribing. So we'd already done some remote prescribing work, again, about December last year, where we were looking for things like stroke thrombolysis. So if someone has a stroke at 2 o'clock in the morning, we want to give a clot-busting medication. We were in a situation that a couple of years back, the doctor would drive from home into hospital to assess the patient and treat them. And we'd moved to something that, only a year ago seemed, relatively advanced, that someone would assess a patient remotely, and then the nursing team who were on site would administer the treatment, with the medic providing video support. We rapidly then had to apply those similar sorts of skill sets in again, a much broader situation. So, so that then changed how we were doing some of our inpatient prescribing, and then also our outpatient prescribing as well. Next slide. So similar principles really then starts to apply with our outpatient prescribing, that the idea that you should prescribe remotely from the patient, suddenly becomes a necessity, whereas before it was, as Rob said, something that's considered at the end of a pathway, and was very much on our trajectory, is that it was something we were going to do, but it wasn't really in the top 5 priorities for us at that time. So our outpatient model, we have been a bit slower than teams like Southampton, but we initially tried it with our rheumatology department. Again, there's some drug builds to consider. So there's some scary medications in some of the outpatient prescribing, and we wanted to make sure that we gain all the safety benefits from outpatient prescribing at the same time as we're gaining the benefits from having the ability to prescribe remotely. We are restricted to using non-controlled drugs. Controlled drugs require a wet script, and we still have to dispense from the hospital dispensary. So again, we have to model that and work out how to best deliver that. So really, we've done a combination of work really on, first of all, moving our vulnerable individuals who are working off site and those who are providing remote clinics. So currently we can have video consultations with patients, we can prescribe their medication remotely, and then they can be picked up from one of our pharmacies on either of the St Helens or the Whiston site. And then we're actually now moving that even for our inpatient clinics, our outpatient clinics, our clinics where you attend to see us in person. So on the 2nd of November, the plan was to roll that out across all of the outpatient clinics. I have currently no idea how many outpatient clinics will even be running by the 2nd of November, but the ones that are will be converted to EPMA, and the ones that won't, we've already got remote clinics done anyway. We don't offer many outpatient clinics at Whiston, but we will do that afterwards. And the reason for that is that this process isn't just about changing the prescriber's behaviour in this, but you also have to change the way the pharmacy works in order to handle the reports and the dispensing. Next slide. So obviously that then brings you the next challenge, which is how do you get the medication to the patient? So again, the historical model, the patients come to see you, you provide them with a paper script. The paper script is walked by the patient down to pharmacy, they hand it in, they sit down in the waiting room along with all the other patients. Their number gets called up, and then they go and collect their medication, off they go. We can't have them all sitting together, and there isn't any paper. So as a result, we do have to now remodel that. So effectively, we've taken it straight out of the playbook of retailers, and so we do a click and collect model effectively, that we provide it for them, and then they go to the local pharmacy, identify themselves, and they collect it from their car, chip and pin payment style. So that's how we've now done it effectively, is with a drive-through pharmacy system. There are discussions about how much we can do with volunteer delivery as well. So if you one model is click and collect, and the other is the Just Eat model, isn't it? So that you can order and have it delivered to you. That's a bit more of a challenge really as to how you can successfully deliver those. But again, it's something that we now have to consider that was absolutely unthinkable only a few months ago. Next slide. I think one of the other interesting things that came out of this was about use of EPMA and clinical trials. So one of our EPMA pharmacists built dummy drugs for the COVID recovery trial. And that meant that you could then check the drug interactions for each of the medication arms of the recovery trial. And that was a really helpful thing that we hadn't really done at any kind of scale at all, and all of a sudden we're doing it with such a major, extremely important clinical trial. So that was a very significant benefit. One of the other things that we found very quickly is that patients who die of COVID tend to have quite significant symptom control needs, more so than I think people experience with some of their other day-to-day experiences of people at end of life. So we needed to adjust the doses of medications that are used to control symptoms at the end of life in those patients. So again, working with our palliative care team, we made sure that we built new protocols to manage symptoms at end of life as well. Next slide. So this has been a very, very interesting phase really in EPMA. I think EPMA is certainly one of those projects that, many of our IT projects, we tend to sort of focus on deployment and then maintenance. And I think certainly our experience of EPMA is it's something that you sort of should continually be pushing the boundaries with. So we've usually got an EPMA board that's ongoing continually, looking at the next phase in our rollout or the next key utilization or expansion of what we're doing. But it's been very interesting that the benefits that we've seen in normal times, so the idea that you don't have to rewrite a Cardex, the reduction in transcribing errors, the ability to prescribe remotely, they're all things that have suddenly been absolutely critical in this pandemic phase. It's been interesting that it has forced us to reprioritize and push boundaries in what we were doing. So our outpatient prescribing was, we've been scheduling an upgrade to the version of EPMA that we're currently using, and we were going to do that first, and then some work on complex infusions and things. Outpatients had to jump the queue in order to support virtual clinics and these different models of working for pharmacy as well as for the clinical teams. And I think hopefully that has given you some idea that this is really part of a pathway, in that there were changes going on to the clinical model, the types of consultation, as well as with the EPMA and the way that the pharmacy worked. And it's really delivering all of those together. I think it's worth saying that certainly we've had good support from WellSky during that process. We've also had good support from a lot of our other suppliers, and I think the suppliers to the NHS in this scenario really have stepped up to the plate. We've made a lot of requests and read queries and tried to do new things with many of the different pieces of software that we utilize as an organisation, and the suppliers have been very good and very, very responsive over that time. It's been a real test of mettle of where the good suppliers are in the system. So next slide. And that's it from me, really. Are there any questions anyone want to?
Hello, Andrew. Thank you very much for a whistle stop presentation, and Rob for your introduction as well. So I can see a question that's come in from Ian Newell. St. Helens and Knowsley are a thought leader and do push boundaries. Hence why rightfully HSJ Trust of year 19. Is Ian on the payroll?
No.
Julian Wynn, with your achievements of rapid rollouts, it could be said that the barrier to the speed of rollout in the past was the mental or psychological barrier of implementers on the provider or supplier side. Is that fair? And if not, what were the major barriers that were overcome by you and your colleagues? Thank you, Julian Wynn.
That's a great question, and I think there is certainly one of the big challenges I think we see, and we're seeing a lot with the Digital Aspirant program generally, is that there is a certain appetite or a certain capacity for change in an organisation at any one time. And I think a lot of what we do depends a little bit on, have you got the resources available to do it? Can you prioritise them for doing the things you currently need to do? Are the clinical teams up for the challenge? And all of those sorts of factors that come into it. I mean, when we've done 5 weeks of EPMA, that was, a fairly good going rate of change. I think one of the key things for me, and I think some organisations would probably have struggled relative to us, is that we had done quite an extensive EPMA rollout before. You know, this wasn't our first rodeo, so that helps a lot that we'd understood the main challenges of how to deploy EPMA out to a new area. We also had a lot of super users out there that already knew what they were doing with the system. Likewise, with Outpatients, we've been very lucky that training people to use Outpatients is teaching them to use 3 extra buttons effectively. There are some people who don't do so much inpatient work who need introducing to EPMA and its wider stuff. But it's certainly been relatively easy to onboard them in terms of changing their prescribing. I think one of the things that we will find with the second phase is that there is a lot more fatigue, I think, amongst organisations. You know, this is now not new, and there hasn't been a lot of downtime between wave 1 and wave 2. And so I think we're still aware there's a lot more to be done and a lot more change that we need to do. Whether that capacity for change is perhaps a bit lessened in wave 2, I think we're going to find out.
Very good. If I may, I'm just going to be cheeky as chair. Rob, if I could bring you in onto something that Andrew said, that suppliers have stepped up, and I've seen that. Now, Rob, our work goes back, and I know that a lot of people won't have seen that for many, many years you've supported the whole health tech industry as a member of the Tech UK Healthcare Council, but also importantly as chair for many years as well. How do you think customers have been to work with during this period, and do you have any comments on what it's been like to interoperate and interact with some of your technology supplier partners as well?
Yes, Shane, thank you. I think, and also in part response to Julian's question in the same way, is that we've seen a massive change across the whole healthcare industry, from both suppliers and from the NHS side themselves. And it's very clear, and Andrew is very gracious, not just to us, but to other suppliers, about how the supplier community has stepped up. And you know yourself from the work we've done at Tech UK and some of the other organizations to be set up, how industry has rallied and looked to engage and support the NHS in a whole host of different areas. Many of the areas get a lot of attention around video, about telecommunications. That's opened up improved communication channels between both parties. And I think that overall that, this has actually tightened and improved the overall relationship between industry and the NHS. I think some of the blockers in the past were not blockers so much as issues about priorities and capacity and capability, something we talked about at industry level for some years, and also at NHS level, about capacity, workforce, and those types of things. And under normal circumstances, as Andrew alluded to, this is a complex system or a complex area to implement at a time where the NHS, even before COVID, was very stretched and under a lot of pressure. And so in this case, it's normal perhaps for the mental psychological side of things that a more steady and gradual and considered approach to implementing digital solutions would take place under normal circumstances. However, these are not normal circumstances, and what it means is how both parties can actually step up, and when necessity is there, and that's where it was recognized and improved, that these types of improvements could be implemented at pace. It is fair to say that it's not uniform. There are other areas where other priorities have taken place and things have stalled or slowed down. But it's definitely been a shift. And it just demonstrates really that I think that neither one party can implement these things without the help of the other. And this has really demonstrated how industry has improved, shall we say, or certainly come to the fore and helped the NHS, who themselves have also worked excessively hard with suppliers to implement these types of solutions.
Thank you, Rob. Andrew, you obviously raised the point that a lot of industry has stepped up, and your partners particularly. How would you react to Rob's response, but also your own experience, not just recently, but reflecting back on a longer journey?
Yeah, I agree. I think we've had a lot of constraints, I think, for a lot of time, and I think while those are still there, you know, there are certain hoops I think you have to jump when you're trying to do a lot of these deployments and things, that it will usually start with, you know, do we have the right equipment? And all of a sudden you're trying to work out where you can get 5 laptops from, for example. You know, the deployment in March was, this is what we need, right, do it then. Yeah. You know, or you're still here. You know, so, you know, the conversation about, well, we need some new we need to get these lap carts in. Oh, we need to do the training via Skype, so we'll need some headsets. Right, fine, next. You know, whereas that's not traditionally the NHS way of making sure you've got the right things on the ground to deploy something. But that has been absolutely essential. That you know, those things sometimes take you a week if you're not careful to sort out, and that's even in a place that's fairly responsive usually at the, you know, at most times. So things like that were very, very helpful. I think the other consideration is that, you know, this is something that we were putting constraints on clinical teams that, you know, before they were kind of used to getting Cardex rewrites and this sort of thing. When you realise there's a very real chance that actually we can't get Cardexes rewritten because GPs might not be able to make it in, you know, so the staff utterly get now this is an essential. It's not a nice to do. You must attend the training because we can't guarantee we're going to have things on the floor to support you. Yeah. So, you know, again, training on a new IT system, you normally have to drag people through getting through a training program to make sure they know how to use a system. Well, again, it was an essential, so people just did it. So I think that was, you know, really, really helpful. And again, I think that supplier relationship has been very different, because I think because both our requirements and their requirements were changing so fast, I think it meant that we could have that better dialogue that said, here's a new use case, here's what we might need for this. And I think that the suppliers have, you know, I think it meant we had this much better partnership and symbiotic relationship going on than we normally see in that sort of normal times.
Great, thank you very much. I think the theme of today, the sessions that we've had, some have been about real frontline activities, some have been very central, some have been international, and some of them have been quite regional. So I don't know how much of you've been able to join us for, but, you know, I genuinely sense it's not just the mass amount of change and adoption that we've achieved over the last 3 to 6 months, but the leveling that COVID has brought in us being equal human beings, that has taken away a lot of the hindrances to change that we've experienced in the past. And there's a great example that you've just given us over the last 45 minutes. So I want to thank you very much for that. But I think what I want to do is pay some acknowledgement to the centre of the NHS, and particularly the NHSX, the NHSDs, who in the past have taken a lot of stick for holding things back. But I complimented Matthew Gould at lunchtime, because I think at the beginning of some of this, he led by saying, okay, what's in the way? Governance is in the way. Let's write a one-pager, crack on. There's Absolutely. The guidance. Yeah, people being sensible with that guidance. What I really complimented him on was coming back in September and saying, hey, industry, do you know what? No one's done anything really bad. Let's keep going. Let's keep that. And I've sensed in other parts of society, and if I look at our own central government, where they've suddenly said, oh, we must come back into the same room. We must all get back into Westminster. You know, actually, the ridiculousness of that. You've demonstrated through the examples you've given that we can find a balance from the emergency that we're dealing with about not bringing people into risky situations, treating them from home, prescribing, and allowing our professionals to do that, and now finding that balance. And I wonder what your hope is, just as we wrap up the last minute, what your hope is for sustaining that balance, or finding your way through the next phase, recognizing that we are I do realize we're going to go into a really tough winter, and it's already started here. But what's your sense of how much we'll be able to keep improving?
Yeah, I mean, I absolutely. I think we're in for a very, very tough winter, and I think that's going to be very difficult. I think certainly in terms of our digital aspirations over the next 12 months or so, we have a program that we have to continue during that time, whilst delivering in, you know, probably some of the worst clinical conditions I think we'll have seen, certainly in my career to date, over those months. I think where we're up to is we're starting to learn about what we can do and how we can model things differently. You know, I now run a weekly video-based clinic for my stroke review patients. I'm quite used to running. I now have models of clinics where effectively I'm seeing some face-to-face, some via telephone, some via telemedicine, and that's the way to do it. I think it would be very interesting that I don't think 100% need to be virtual. I don't think the answer is 0 either. And I think what we'll find, and hopefully our aspiration will be, is where is that sweet spot, and how do we find that over, you know, when we've not got the necessity that is COVID, insisting that these things are all virtual. What's the best benefit? What's the best ratio to have for those sorts of services?
I think that's what we hope for, is that people are going to say, we've seen a shift, we're not sure where it'll finish, but we're going to keep learning. And that's the great thing, is to keep learning. Rob, if I may, we're just up against the clock for a minute, but if I may just bring you back in for any final words on that.
Yeah, just one final thing, so thoughts to take away is what we're seeing really, a lot of organizations are preparing for the next wave, which we now, and they've been talking about this for some time. And you mentioned NHSX and the government. This is very much a sort of a three-way here. If the organizations at the top continue to support the digital programs that are going forward and support the organizations like Andrew's to move these agendas forward, then we can jointly with industry is improve the overall, area of digital maturity within the NHS, which will enable and support what is going to be a very difficult period, both in this winter and arguably into the first half of next year.
Thank you very much. Thank you, Rob and Andrew. Rob, thank you very much to WellSky for being part of and helping make this overall day happen, which we couldn't do without sponsorship. So I want to thank you very much for that. Andrew, thank you so much for taking the time.
So welcome.
It's been an absolute pleasure and a privilege to have you. We're going to wrap